Session 1 is about level setting and understanding the building blocks of our training as primary care physicians, and really our indoctrination into the culture of medicine. Not everyone has access to physicians outside of their doctor patient relationships to get a scoop of what it's like to become one. We pull back the veil a bit to share our experiences about the medical culture because having this context is really important in understanding how doctors are trained to think and why our profession is sometimes so set in their ways and resist change. I think you'll really enjoy the section about primary care physician archetypes that can only be gleaned from years of work in the trenches to appreciate the different personas behind the PCP label. Let's dig in, and I'll let Kenneth take it away.
Every doctor goes through 3 phases: a med student, a resident, and an attending. At the med student level, this is where a layperson becomes a healthcare professional, or at least tries. Everybody knows that med school is hard and there's a ton of information, often likened to drinking from a fire hose. What people don't know is how med students are able to take all that information and make it manageable. 2 of the big ways that are often joked about in med school are buzzwords and high-yield facts. Buzzwords are just that. We listen for certain words or phrases that are often associated with other words or phrases, commonly a clinical presentation to a diagnosis. For example, coffee ground emesis. In other words, if your vomit looks like coffee, then you probably have bleeding in your stomach or somewhere in your upper GI system. The other one is high-yield facts. So during any given lecture or section, med students will frequently ask each other, what is high yield? And in this question, they're not really asking, what do I need to spend more time on? They're saying, what are the things that I can ignore? As in, all the things that are low yield are not worth my time and I will probably not learn them. And these things are important because if you think about this type of thinking that starts early in a doctor's training, we're already starting to do 2 things. 1, listen for things that are important, and 2, filter out the noise so that we can actually focus on what's really pertinent to whatever situation is happening. In addition to all the textbook information and the lectures, med students are also starting to form their clinical skills. Usually the first thing you learn is how to take a history, which is the art of talking to a patient and turning patient words into doctor words. The first part of a patient history is the chief complaint, so understanding what the patient comes in for. If anyone's been to a doctor, the question that you may hear, which is the first thing we're taught to ask, is, what brings you in today? It's supposed to be open-ended so that the patient can say anything and everything. And from that chief complaint, the med student then learns to form a differential diagnosis, which is a list of all the possible things that the chief complaint can be. For example, if it's sore throat, whether it's an infection, a trauma, or any other cause, cancer, it's almost always cancer. Early med school is kind of like WebMD, where you always have to say cancer is on the table. But for the clinical side, the med student is pretty much your generalist. They can be presented with any chief complaint and have to make sure that they hit every single differential. Then, after 4 years of medical school, the med student goes into residency. So in residency, you have to pick your specialty. And most primary care residencies are 3 years long. Family medicine is the most common primary care specialty, and it's also the specialty both Paulius and I are trained in. For the purposes of this course, we'll talk about family medicine training. So family medicine training is probably the most broad. We call it womb to tomb or cradle to grave training because we take care of patients from pregnancy all the way to end of life and across all the different care settings, whether it's emergency room, ICU, hospital, or outpatient. Of course, our focus is the outpatient clinic. We do rotations with specialists in multiple settings so that we have a good understanding of what happens in each setting and have context for when we're treating our patients in the office. Residency is like practicing independently, but with a safety net. So we are making orders prescribing medications, but we have faculty who co-sign all of our orders and sit there and make sure we don't do anything crazy. Just like medical school, residency, for the most part, leans more academically. And so there's journal clubs. We're encouraged to keep up with the most recent guidelines and literature. And so there's something called evidence-based medicine, which is doing things based on science, which should be pretty self-explanatory, but the whole evidence-based medicine movement is fairly new, I believe, from the 90s. But also during residency, because we interact with faculty, we're also exposed to experience-based medicine, which is older docs saying, we've always done things this way, or I've seen this work X many number of times, therefore this is truth. And sometimes it's even in the face of the evidence. They're saying, yeah, that paper says this, but this never works for my patients, or this always works for my patients, so just ignore the papers. It's interesting as a resident to experience both rigorous scientific thinking as well as experience-based hierarchical thinking. And because residency is specialty focused, unlike during med school where you are the generalist and can have every chief complaint and have to have the widest differential, things tend to become repetitive. So in the family practice office, hypertension, diabetes, obesity, high cholesterol, joint pain, anxiety, depression are some of the most common issues. And because you start seeing the same things over and over, you start to form habits. The chief complaints start looking the same, and the differential starts to shrink a little bit and focus more on what you're seeing. Then after residency, you become an attending. All the thinking, all the habit forming, whatever thinking momentum you started to develop as a resident continues throughout residency, but now you also have real life things to deal with, for example, finances. And that's where motivations come to play. So it's the same type of academic thinking, but now some real world factors come into play, and we'll cover those motivations in session 2. And just like everything else in the world, there are certain archetypes for different doctors. Just like Myers-Briggs, where there's extrovert, introvert, feeling, thinking, and the dichotomy, there are often two sides of a coin for PCP archetypes. The first one is bleeding heart versus entrepreneur, which is not the most obvious dichotomy, but the bleeding heart is a lot of family doctors where they believe that no matter what happens to them, they should and must endure it for the sake of their patient. This means double booking, triple booking their schedule so that they can get people in. If the patient is super late, 30 minutes late, and the cutoff time was 15 minutes, they'll still squeeze them in, even if the doctor's running 2 hours behind already anyways. They'll stay for hours doing what's called pajama time, meaning charting at home. Actually, one of the rural docs I worked with, his wife told me that he would frequently chart until 1 in the morning when clinic ended at 6. And he was older. I don't know how he did that. On the flip side is the entrepreneur who just doesn't put up with it. So a lot of direct primary care docs, the early ones, are this entrepreneur type where they said, I don't have to put up with this. This is not for me. I'm going to do my own thing. And then they went and started their own practices. And you'll see this entrepreneur type also leave medicine, go into consulting, real estate investment, or whatever else. The next dichotomy is the rule follower versus the renegade. The rule follower, whether they are more scientific or at least put on the facade to be more scientific, will be the type of person who will always have a paper for everything, have very strict protocols, never waver from any guidelines. They tend to do really well when there is a guideline, when there is a study. These people tend to have a hard time when there's some ambiguity in the world and will always try to fall back on some sort of published paper. On the other side is the renegade, who relies more on experience, and if anybody calls them out on it, they'll try to find a paper to justify what they wanted to do anyways. This is actually a manifestation or a characterization of what we talked about earlier with evidence-based medicine versus experience-based medicine. The rule follower will be embodiment of evidence-based medicine, and the renegade is an embodiment of experience-based medicine. And of course, all of these are on a spectrum. But you do see doctors who tend to rely more on their own opinions and other people who rely a lot more heavily on papers. The next dichotomy is the investigator versus the dismisser. The investigator is somebody who forever is a med student at heart. What that means is they will forever have a differential that is 20 diagnoses long, and they will want to work up everything. For example, fatigue, most likely patient is not sleeping enough, eating poorly, stressed out, but an investigator will order every single blood test known to man, maybe even some imaging, and just go down what we call the $1 million workup, meaning just try to do everything to figure out what's going on. On the other side of it is the dismisser, who often people talk about in the news or comes up where they just say, "Oh, you're fine. It's anxiety." There's actually a New York Times article where the person talked about how their doctor was killed, or they were afraid their doctor was going to kill them because they came in with neck pain. The doctor said, "Oh, it's probably because you're hunched over at your desk," and then walked out the door without doing an exam. So those people do exist. And so it's interesting because when it comes to media, usually you hear more about investigators in specific healthcare articles talking about how doctors make everything more expensive, and it's because of the investigators who are ordering all the tests. And then in more popular mainstream media, you hear more so about dismissers who aren't doing appropriate workups and just tell patients, "Oh, you're overreacting. It's just anxiety." But again, people tend to fall on a spectrum. They're not generally one or the other. The next dichotomy is jack of all trades versus referralist. So the jack of all trades, we think of the rural doc who has no resources or anything, just has to do everything. Frequently, if they haven't done a procedure in a while, they'll go on YouTube, watch it, and then go in and just take care of it. Meanwhile, on the other hand, you see this, of course, more in urban settings where there's more resources and in hospital systems where the incentives line up, the referralist who doesn't actually do anything. And these are the people who get complained about on social media where they're like, do family doctors even do anything? Because all they do is refer, right? So knee pain, ortho, chest pain, cardiology, weakness or fatigue, endocrinology, rheumatology, right? They know who to send people to, and they don't actually do anything themselves. And then the final one, the non-clinician. So there are some people who, after a decade worth of training, will decide, clinical medicine sucks. And then they'll move into business as a consultant. They'll try to be an influencer on social media. And actually, some people who still like the science, but not so much the patient care, move into academic and just choose to write papers. And similarly, administration, whether it's at a medical school or a hospital, where they would rather manage doctors than manage patients. But the funny thing is, on LinkedIn, all of these non-clinicians will make sure you know, and they will make sure to repeat to you that they are physicians. And then there is the floater. So floaters, even if they are primary care trained, will move doing locums, ER, urgent care, shift work. They realize continuity is not really their thing, or wherever they are in life, they just prefer to explore other options rather than stay in one place for an extended period of time.
To summarize, we just learned about the education progression of primary care physicians from medical student days all the way to attending hood. Briefly, we reviewed high-level concepts about our clinical reasoning and took a glimpse at the different PCP archetypes. This concludes session 1.